Good afternoon. I'm John with the Illinois chapter of the AAP. We thank you for joining us for today's webinar on the business side of vaccines, coding for immunization services. This webinar is sponsored by the Illinois and Chicago Department of Public Health. Today we are joined by Becky Dolan from the American Academy of Pediatrics. In accordance with the requirements of the FDA, the audience is advised that information presented in this continuing medical education activity may contain references to unlabeled or unapproved uses of drugs or devices. Please refer to the FDA-approved package insert for each drug and device for full prescribing and utilization information. The course directors, planners, faculty, and reviewers of this activity have no relevant financial relationships to disclose. Evaluations will be sent post-webinar by ICAP with a link to the survey to be completed. You'll have 2 weeks to complete the survey. The survey will be closed after July 28th, so please make sure you complete it before then. Once the survey is complete, you will receive your certificate via email from ICAP within 2 weeks of completion. Participant phone lines are muted. This webinar is being recorded. If you have any questions for our speaker during the presentation, please enter them into the question box on your control panel on the right side of your screen, and Mrs. Dolan will answer them at the end of the presentation. After this webinar, you will receive an email with a link to the recording of today's webinar, as well as a PDF of the PowerPoint slides. Now I would like to introduce Becky Dolan. Mrs. Dolan holds a master's degree in public health education from Tulane University. She has spent the last 8 years at the American Academy of Pediatrics working in the Department of Practice on Coding, private payer, and Medicaid issues. She is a certified professional and pediatric coder through the American Academy of Professional Coders. Previous to starting her work with the AAP, she spent over 10 years working in a private pediatric office where she worked in the front office in coding and billing and was also part of the clinical staff. Please join me in welcoming Becky Dolan.
Thank you very much, John, and welcome everyone today to the coding webinar on immunization services. Sorry about that, we had a technical difficulty. As John mentioned, here's the continuing education information. And I do not have anything to disclose. Anything I discussed today is strictly for coding purposes. Here are the objectives for today. Just quickly want to run over them. You want at the end to be able to differentiate when and how to use the 6 vaccine administration codes and how private payers and Medicaid do differ on this. Be able to properly code for vaccine products. Understand how to handle administering of new vaccine products to ensure payment from payers or families. And learn how to code for some vaccine-only encounters. And again, how private payers and Medicaid do differ on this topic. I promise this won't hurt a bit. I know it's a beautiful day, at least here in Chicago, so hopefully I can get you through quickly and you can enjoy a little bit of the day. So why is this important? It's important to be able to accurately capture both CPT and ICD-10 coding. It allows for possibility of increased appropriate payment, it decreases your liability, and it also improves information flow both to the payers and for quality metrics. We're going to first talk about ICD-10 CM reporting as it relates to immunizations. We are now about 9 months into ICD-10, and I'm hoping everyone out there is feeling more comfortable with ICD-10, but there's still a lot of hiccups and bumps that we're all working through as we approach the 1-year anniversary of ICD-10. So as you're all aware, ICD reporting for vaccines has changed pretty significantly from I-9 to I-10. What did change? We have one code now, one ICD-10 code to define vaccine encounters. We used to have several different ICD-9 codes that were specific to the vaccine being given. Now we have a single code. This single code is required to be reported in addition to any well-child check ICD-10 code. And again, that was not the case in ICD-9. So again, we've seen some big changes just even with vaccine administration when it comes to ICD-10-CM. The code you will use is the Z23, which I'm sure by now everybody is very familiar with. You use this code regardless of the encounter type. So you're going to use it whether the patient is there for a well child or for some other encounter where vaccines will also be administered. So for example, a 6-year-old presents to the pediatrician for atopic dermatitis. During the encounter, the pediatrician determines that they need their flu vaccine. The physician counsels on it and it is given. Your ICD-10 codes have to be the L20.89 for your atopic derm and the Z23 for your encounter for immunization. And again, the product code is to tell the payer what specifically was given. Another quick example, a 6-month-old presents for their well child check. The baby's healthy, vaccines are ordered, and they're given. You will report the Z00.129 for the exam for routine child health without abnormal findings, and a Z23, because you have to have that Z23 in addition to either your Z00121 or your Z00129. This is where things differ from ICD-9. Next, we're going to talk about the CPT side, which is a little more complex and cumbersome than the ICD side. First, I'm going to introduce our Pediatric Immunization Administration codes. These codes have been around for quite some time now. However, through the AAP's coding hotline, I still get numerous questions about these codes and numerous scenarios where I notice that people are not using it as appropriately as they should. This is why I want to spend a little bit of time going over this. We have two codes, 90460 and 90461. 90461 is an add-on code to 90460 and is only to be used when a single vaccine has a multiple component. So the 90460 we use for our administration of the actual vaccine. It's for someone who's through 18 years of age. Any route of administration, it may be oral, intranasal, or an actual injection. There must be counseling by a physician or other qualified healthcare professional. And again, the 90460 represents the first or only component of each vaccine or toxoid administered. The 90461 is then added if a single vaccine has an additional component beyond the first. To clarify some of this, we get a lot of questions about other qualified healthcare professional, even, again, years after this has been in place. And an other qualified healthcare professional, in a nutshell, is someone who can bill under their own NPI. That is the major difference. Clinical staff are those people who work under a physician or qualified healthcare professional. When we think about our qualified healthcare professionals, we think about physicians, nurse practitioners, physician assistants, registered dietitians, etc. They are not people who work underneath them and have to bill under the physician or other qualified healthcare professional. Clinical staff are not considered qualified healthcare professional by CPT. When these codes were first created, we had hoped by state licensure would dictate that. Unfortunately, CPT did not agree with us. So again, a clinical staff person would be a registered nurse, a nursing assistant, LPN, anyone who is not able to bill under their own NPI. And again, there are other restrictions as well. They have to be able to do this under their licensure and regulation, and again, privileging within a facility when applicable. So that is the main difference between the two. So if they're not able to bill on their own, then they cannot be considered other qualified healthcare professional. If they can and they counsel, we can use that 90460-61 code. Another question we get a lot are, what are components? So what is a vaccine component? And again, it refers to each antigen in a vaccine that prevents disease caused by one organism. Conjugates or adjuvants contained in vaccines are not considered to be components of the vaccine. Multivalent antigens or multiple serotypes of antigens against a single organism are considered a single component of vaccines. So if we take a look at that, the HPV is a single component vaccine, so it would only be reported with the 90460. Same for the influenza. No matter how many different strains we have in there, it's a single component. The pneumococcal, the Prevnar 13, we get asked about that a lot. That is a single component vaccine, 90460. And further down, you see more examples. The MMR is a 3-component vaccine. You know, we've used that vaccine for years. A lot of us don't consider that a 3-component vaccine, but it is. 3 different organisms: measles, mumps, rubella. 3 components. Then it goes further down to the Pentacell and the pediatrics, which are both 5-component vaccines. And then broken down by how you would report the immunization administration codes for those patients who are 18 years or younger with physician or qualified healthcare professional counseling. So again, your 90460 for the first component of your Pentacell, and then 4 additional 90461s for each additional component beyond the first. So that's why it's 90460 with 1 unit and 90461 with 4 units. Again, we still get a lot of questions about the difference between the 90460, 61, and what we consider our non-pediatric vaccines. So sometimes it might help to think a little bit in a flow chart. So you ask yourself, is the patient 18 years of age or younger? The answer is no. Then you will not use the 90460, 61. You'll be deferred to our other immunization administration codes, the 71 through 74, which we'll talk about here in a minute. If the answer is yes, then you have to next look at, is there documented physician or other qualified healthcare professional counseling on the same day? The answer is no. Again, we refer to our 90471 through 74. The answer is yes. To both questions, we report our 90460, 61 as appropriate. And again, counseling by the registered nurse or other type of nurse that's not a nurse practitioner is not considered other qualified healthcare professionals. So again, in a nutshell, if both criteria are not met for reporting the 90460, 61, we defer to our 90471, 72, 73, or 74. Now these are non-age specific immunization administration. We don't want to confuse that you can't give it to you can't report it with pediatric patients. It's just non-age specific. So if we don't have our 2 criteria met for the 90460, 61, we defer here to our 90471 through 74 series. Now let's break these down. The 90471 is for 1 vaccine, and that includes a percutaneous, intradermal, sub-Q, IM. 90472 is for each additional vaccine given by injection. 90473 is specifically when we have an oral or intranasal vaccine. 90474 is for each additional oral or intranasal vaccine. Remember, you will report your additional injection code, or 90472, in addition to 90471 or 90473. You will report 90474 in addition to your 90471 or 73. You will never report 90471, which is your initial injection, with 90473, which is your initial oral. Only 1 initial or first vaccine code can be reported per patient per encounter. So do not report the 90471 in addition to the 90473. Once you have listed one of those codes for that day, all other vaccines administered must be reported with each additional code. So either your 72 if it's an injection, or the 74 if it's intranasal. This is just another chart to distinguish between the 2. Again, requires physician or other qualified healthcare professional counseling. That's only for the 6061. Reported based on route of administration. It's only the 71 through 74. 90460 does not distinguish that way. Your 9046061 is reported per component versus the 90471 through 74, which is reported per vaccine. We don't care how many components are in that vaccine. If you're reporting the 71 through 74 because you do not meet the 6061 criteria, it will not matter how many components. It only matters how many actual injections were given or oral vaccines or intranasal. We don't care about components. The 6061 are the only ones with the specific age requirement. You can only use the 6061 on patients that are 18 years of age or younger. We also get a lot of questions about counseling in IA. What constitutes counseling? And this has kind of been brought up by some payers as well. This is not like E&M. We don't have specific documentation guidelines, but we do provide some general guidance for what really does encompass the counseling. So they must document that all vaccine components were counseled on. Which ones were counseled on, I should say. Documentation should reflect what was done, including the parent-guardian receipt of the VIS, the vaccine information sheet, risks and benefits of vaccine components that were discussed, any issues or concerns that were addressed by the parents. Now, physicians are spending a lot of time discussing these with families, and that should be documented. The care plan over the next few days to deal with any possible side effects of each component and when to call the office. And again, this is just guidance, not official documentation guidelines. These are just some things the physician might want to be jotting down in order to show that they did indeed counsel on these vaccines. Now, if your physician or the other qualified healthcare professional does not counsel on all the vaccines given, then you cannot report the 9046061 for all of them. You will only report the 6061 for those that you actually counseled on. For those vaccines not counseled, you will defer to the 90471 through 74. Again, in the same spirit as the non-pediatric IA codes, you can only report one, what we call our first or initial code. So the CPD guidelines do state to report 90472 or 74 in addition to the 90460 during those encounters where a vaccine may not have any counseling. You will not report the 71 or 73 with the 90460. Those are excluded. So for example, your physician does counsel a mom on the MMR, but not the annual influenza. And that is given intranasally, which, as you'll find out later on, we will not be doing this year. So we will report 90460 and 61 with 2 units for the MMR because that was documented as counseled on by the physician. However, because the intranasal vaccine was not counseled on, you will report the 90474, not the 73. So the second part of the CPT component here would be our vaccine products. Every vaccine given, of course, Illinois Medicaid excludes this. You will report a CPT code for the administration and a CPT code for the actual product. So again, these are found in the medicine section of the CPT manual. They run from codes 90476 through 90749. These identify the specific vaccine product only. You will use in addition to administration codes, again, except for Illinois Medicaid. So some of the common vaccine codes, which I'm sure a lot of you already have memorized, I still can recall these from my years in practice: DTaP 90700, IPV 90713, Hep B 90744. So again, you always report the product code that matches the product that you have given. Vaccine product codes are part of the CPT nomenclature. They are released twice per year, unlike regular CPT codes, which are released only once in January. They can be updated twice a year. And this is in order to afford a quick deliverable. Once the vaccine has been approved by the FDA, the code is already in place. So again, codes posted on January 1st become effective the following July 1st. and codes posted on July 1st become effective the following January 1st. It's important to note that vaccine product codes are often released before the vaccine is even on the market, and again, that's to aid when the vaccine comes out that you have the code in place. And always pay attention to the lightning bolt indicator. It indicates the vaccine is pending FDA approval. Do not report a code with FDA pending status unless you have prior approval from the payer to do so in writing. You can refer to the AMA for the site of updated lists. Again, these are updated twice a year, right just after January 1 and just after July 1. That is a link at the bottom of the page if you would choose to bookmark that. So remember, without FDA approval and the CDC's Advisory Committee for Immunization Practices, or what we'll refer to as ACIP, or AAP, AAFP, routine recommendations, a vaccine will not be covered by most, if not all, payers. It's important to remember. For more information on that, always look to the CDC or ACIP website, which is listed here, as well as the AAP's Red Book, which is also listed on this page. It is very important to keep up with routine recommendations in order to eliminate any issues with payment from payers. Most payers do follow these guidelines. So again, we want to report the CPT code that most accurately identifies the product you're giving. You're going to look at the product. Is it a combination versus single component? What disease are you targeting? For example, hepatitis B. The dosing schedule. Some are listed in CPT by dosing schedule. Either they're a 2-dose or a 3-dose. The chemical formulation, such as is it a polysaccharide or a conjugate? And again, the route of administration. We're seeing a lot more influenza intradermal codes, so we want to be careful when we're reporting these new codes that are we giving it by sub-Q, by intramuscular, or intradermal. Codes are specifically written this way. So just real brief, most of you know this already. If you're going to do a combination versus a single component vaccine, make sure you are reporting the multiple component vaccine product. You will not report a lot of these at individually. So if you're giving the MMR, report the MMR code, not the measles code, then the mumps code, then the rubella. And you'll probably notice they're actually removing a lot of these single component codes because they are not manufactured and marketed any longer. So you will see some of these codes being removed from the CPT nomenclature. Now we're going to talk about some product changes we're going to see upcoming that it became effective July 1 or that we'll see in the new 2017 CPT manual. Again, just a real brief look at the CPT symbols for updates. Again, we talked about the FDA approval pending lightning bolt. The dot is the new code, triangle is a revised code, and the hashtag is a resequenced code. So these product codes were updated in 2016 that will be valid in 2017. If you'll notice, all the vaccine product codes were revised. What they decided to do was remove the age criteria. It is now based on the actual dosage. They're trying to remove a lot of age references and strictly use it basically how the FDA looks at it, and it's the 0.25 ml dose or the 0.5 ml dose. This is just to give you an idea. So if you start seeing triangles all over for these codes, it's just simply the fact they removed the age and now have the dosage. Some more revised codes. Again, we're not really giving most of these. I think this one is for 18 and older, the influenza virus vaccine. They just added trivalent and again updated the dose. And then they updated some of the language here in the meningococcal conjugate vaccine. But again, the vaccine and how you're going to use it will not change. It'll still be for the same vaccine products. Some new codes, again, more and more influenza virus vaccine codes coming out. This is a quadrivalent from cell cultures, preservative and antibiotic free. 0.5 ml dose. This one will be coming out in January. Another one is the influenza virus quadrivalent. Again, we're not using a whole lot of these in pediatrics just yet, but I think in the near future that we'll see more and more of these. And again, we rarely use the zoster, but again, I just wanted to point out these are all the new codes that will be coming out January 1. These two vaccines were now given FDA approval, so they will be removed with the lightning bolt. Probably not giving too many cholera vaccines in your office, but if you are, it's now been FDA approved. And the influenza vaccine inactive, subunit, adjuvanted for IM use, that one is now FDA approved. So we are moving into influenza season, if you can believe that, with the beautiful weather we're having. It's important to remember that the 16-17 will now again contain trivalent and quadrivalent forms. Be sure to keep an eye out for that. Also, a huge change for this year is that the flu mist, or the live virus intranasal, is not going to be recommended by either ACIP or AAP in 2016-2017 for use. This is just a chart that kind of goes over all the different vaccines and which are trivalent, which are quadrivalent, with their respective CPT codes. I'm not going to go over this. It's just a chart for your reference. So again, we want to talk a little bit more about vaccine product coverage because this is very important. Again, I don't want to go over this, but we don't want to report vaccines that have not been prior approval by the payer for not off-label use, because we don't really care about the off-label here. We care about CDC and ACIP recommendations or AAP recommendations. If the vaccine has not been routinely recommended for that particular patient, whether it's by age group or specific issues the patient might have, you need to get prior approval from the payer in writing for coverage. This is to protect you and protect the family. Again, payer coverage does depend on ACIP recommendations. I don't know of too many payers that go against ACIP recommendations. Public recommendations are published in the MMWR, which is the Morbidity and Mortality Weekly Review, and that is published by CDC. It could depend on AAP recommendations, which typically follow ACIP, but some might vary. I don't know of too many, but there have been some variations over the year. Again, never simply follow the manufacturer's recommendation. That provides safe use. It does not provide routine recommendations. So always refer to ACIP or the AAP. Now remember that time between FDA approval of a vaccine and released recommendations by either ACIP or AAP can take some time. They have to go through a lot of information and work through a lot of work groups in order to come out with the recommendation. So simply because a vaccine is approved by the FDA does not automatically mean you should be reporting it. We need to make sure that the ACIP recommendations are out. And again, if they're not and you feel the patient needs that vaccine, you need to speak with the payer and get it in writing that they will cover it. And just to reiterate, the ACIP recommendations do not recommend the live intranasal vaccine this year. The Academy did come out with a website for some helpful information if you've already ordered yours, and some practices have already begun to order their influenza. So if you go to this site here, they provide some information on how to handle it if you have already ordered your vaccines for the year. If you have not, we do not recommend ordering the live intranasal for this next year because it is not recommended. We do believe it's going to be manufactured, but again, you may have issues with payer coverage. So let's talk a little bit about payment for vaccine products. This is different than coding. So we get the coding right, that's great. We figured out how to navigate how the administration codes, the product codes, that's great. But the main piece of this is what is the outcome? What is the payment from the payer? And the Academy has worked a lot on this issue because we've understood that Vaccine products is not just like you walk into a store and it's a one-for-one. You need to be able to take into account payment for the product itself. So how much did that product actually cost you when you purchased it? Again, here's a great resource for anyone who's interested in what the CDC puts out as private sector dosing cost. It's a fantastic resource. You really should have this bookmarked for anyone who does your vaccine ordering or anyone who deals with the payment side of vaccines. The second thing it should take into account is the personnel costs. All the costs for ordering and inventory, storage costs. You are required to store these vaccines now. Insurance against the loss of vaccines. No matter how hard we try, things happen. There was a big storm that came through Illinois yesterday, and lots of people lost power, and there was some flooding. So you always have to make sure you have insurance against the loss of vaccines. Recovery of costs attributable to inventory shrinkage, wastage, and non-payment. A patient refuses after a vaccine is drawn, and this is a topic where I'm actually going to talk about in a few minutes. Lost opportunity costs. So the cost of you having to maintain a large vaccine inventory within your practice. That's costly, and that is something that needs to be built into the actual product payment itself. So the AAP says that payments must be free of any discounts and based on a transparent and verifiable data source, such as the CDC vaccine price list. Again, you see the previous slide for the link to that. Cover the vaccine product purchase price as well as all related office expenses as noted in the last slide, and a return on investment. This is an investment for your practice. No one really wants to think about that or look at that, but it's an investment. And you want it to be at least 125% of the current CDC vaccine price list for the private sector. Again, we're going to refer to the CDC private sector cost site that we listed in the last slide. But what happens if, after you learn all this, you're realizing your payments are not where they should be? Be sure to read over your contracts with each payer. I know that seems cumbersome and tiresome, but it's important. You need to know your rights. You need to know what the payer is supposed to be doing. Make sure they are paying what was negotiated in your contract. If they are, use this information when it's time to renegotiate your contract. Say, here's what I'm paying. Here's what you're paying. You need to be above this line. The American Academy of Pediatrics advocates for this very strongly. Remind the payer that these indirect costs, so all those things we kind of went over in the previous slide, they're not taken into account during vaccine administration. Those codes have different things built into them. They're for that actual moment when that vaccine is given. The product, however, has other indirect costs that payers don't always think about. So you must do the thinking for them. So this is a pretty hot topic lately, vaccines not being given. A lot of physicians are spending a lot of time with families who are vaccine refusers or want to delay vaccines or are vaccine hesitant. So like ICD-9, ICD-10 does contain codes that allow the physician to report vaccinations that have not been administered. You will report these as a secondary diagnosis code only. They're not typically primary. So here's a list. If we have an acute illness or a chronic illness or condition that impugns us from giving the vaccine, we have an immune-compromised patient, there might be an allergy, or the caregiver refuses or a patient refuses. They refuse due to religious reasons. Patient might have had the disease, or there's just other or unspecified reasons why the vaccine was not carried out. But these are important to list. So be sure if a patient is not getting a vaccine the day they are in and are due, you're noting why the vaccine is not carried out. Quality metrics are looking for vaccine rates, and they need to know why something wasn't given on that date of service. So let's look at a real quick example here. So a 13-month-old presents for their well child check. The parent is informed that the child will need her MMR and varicella vaccines. The mom refuses, stating she believes both vaccines are harmful and would like her child to be older. Despite counseling efforts by the physician, the mom still refuses. So in this case, we're going to report our preventive medicine service, and we're going to link that to our routine ICD code, the Z00129. The patient was there for encounter for vaccines, but they refused. Vaccination not carried out because of caregiver refusal. You want that code in there. Again, this shows the payer that they were due. You recognize they were due. Vaccine was not carried out due to caregiver refusal. I'm getting this question a lot more these days, so I wanted to bring up a scenario. A patient or parent is told what vaccines they are needed. They are counseled on the vaccines and have agreed to get the recommended vaccines. After they are drawn up and brought into the room, the patient or parent then decides they do not want them and refuse administration. So what are your options? Are you simply out the money? Well, unless you can actually reuse that vaccine probably within the same day, that vaccine is most likely wasted. So don't wait for these situations to happen. We highly suggest preparing for these situations in advance. So check into your payer contracts about this. Medicare has a lot of information on wastage. So check and see if your payers actually address this in any of your contracts. We also recommend contacting legal counsel about drafting an office policy that makes the parent or patient financially responsible for any costs for these vaccines if you indeed cannot use them. And learn some coding options that you may have, especially if you find out your payer will cover some of this. Again, we keep in mind that the AAP fights for vaccine product payment above and beyond cost to account for some wastage. But if this is happening frequently in your practice, especially on some of the very expensive vaccines, you need to be able to be compensated above and beyond what goes into the wastage cost. Some payers allow for payment when the code is submitted with the JW modifier. So you would actually submit the product code for the specific vaccine, identify it with the JW modifier so that the payer is aware that the vaccine was not given. This was a wasted product. And again, they may pay. This is individual payer contracts, which is why I recommend it. However, I think our strongest point is to talk with legal counsel to ensure that you can actually drop off this policy. This is once you've signed and said, yes, we want these vaccines, that as soon as they're drawn, the family could be financially liable for that. This is another important ICD code, the under immunization status code. So this will be used for those patients who do refuse the vaccines. Z28.3 is under immunization status, lapsed immunization schedule status, or delinquent status. So use this code as appropriately. Again, this points out to the payer that yes, you recognize this family is under immunized. This might come in handy if there's any counseling sessions that are done with the families, or just to note it during any encounter that you recognize this patient is under immunized, but they're still refusing for whatever reason, or because they have a certain immune compromised system that will not allow certain vaccines. So next big topic that comes up quite often is immunization administration and evaluation management services. Most people won't argue that if a patient comes in for their well child check, you're going to report that well child check in addition to your vaccine services. However, this is for encounters when a patient may come in either strictly for vaccines or for other services. So we're talking about sick encounters, not your well child checks. So if a patient presents for immunization administration and a significant and separately identifiable E&M service is performed, the appropriate E&M service code should be reported in addition to the vaccine administration codes and product codes. Modifier 25 will be required when reporting a problem-oriented E&M service in addition to immunization administration. Now you have to think about that because you have to remember what modifier 25 means and the definition of that. Modifier 25 should not be required when reporting immunization administration in addition to preventive medicine services, The exception now, though, is our NCCI edits. It never should have been this way, but it is now. So again, let's think about modifier 25. What is our modifier 25? It's defined as a significant and separately identifiable E&M service by the same physician or other healthcare professional on the same day of the procedure or other service. The E&M service should be above and beyond the other service provided and substantiated by documentation that does meet the relevant criteria for that E&M service. It must be medically indicated and necessary. So that's what a modifier 25 means. So when you're using it, you're telling the payer all of these things. So what happens when it's a vaccine-only encounter? A patient presents for the sole purpose of vaccines, and that's very common during influenza season. It's also common when a patient might need a second or third HPV. If the vaccine is the only thing that is addressed and nothing else is brought up, you will code only for the vaccine administration and the product. You do not report a separate E&M service for vaccine-only visits unless the service meets the criteria for using modifier 25. What about the 99211? The 99211 is our lowest level established patient. It's commonly referred to as the nurse visit since this does not require any key components nor face-to-face encounter with the physician or qualified healthcare professional. When a patient sees the nurse only for immunizations, when should a 99211 be reported in addition to the vaccine product and immunization administration code? Well, we should first look at what's included in our immunization administration. What's included is administrative staff services such as making the appointment, preparing the patient chart, billing for the service, and filing the chart. Our clinical staff services include greeting the patient, taking routine vital signs, obtaining a vaccine history on past reactions and contraindications, presenting the patient or family with a vaccine information sheet, and answering routine vaccine questions. Also will include preparing and administering the vaccine with chart documentation and observing for any immediate reaction. So all of that is included in your vaccine administration codes. And that's a lot, which is why we say nothing to do with the product has anything to do with the vaccine administration codes. So what additional services are required to appropriately report 99211? Well, first, the service must be medically necessary. The service must be separate and significant from the immunization administration. The nurse has to evaluate, manage, and document the significant and separate complaint or problem unrelated to the actual immunization administration. So what should be documented to support the 211? Obviously, your date of service and reason for the visit, a brief history of any significant problems evaluated or managed, any exam elements, vital signs or appearance of a rash, a brief assessment and or plan along with any counseling or patient education done, signatures of the nurse and supervising physician. Again, all unrelated to the vaccine administration, unless of course this has to do with a reaction to the vaccine. That would be separate. Let's look at Illinois Medicaid. They take exception to this rule. Private payers do not. Under Illinois Medicaid, it states that reimbursement for the practice expense of administering the injection is included in the office visit when the client sees a practitioner. If the client comes in solely for the injection, the CPT code for a minimal level office or other outpatient visit for evaluation and management not requiring the presence of a physician, which is our 99211, may be submitted to cover the practice expense, and the specific vaccine procedure code is to be submitted to cover the cost of the vaccine or the cost obtaining it through VFC. Seasonal flu vaccinations follow these guidelines. So Illinois Medicaid does a 180 from the rest of the world, and they say, nope, it's always okay, because they recognize the fact that they pay very small for the product itself, that they don't take into account any overhead expenses or indirect costs. So that is why they do allow that. I do want to bring this up because it does come up from time to time. Modifier 33, it's used sparingly. We're not still 100% sure if it's made much of a difference by using this, but this is really related to any time a payer will put cost sharing back onto the family for any recommended service, either by the AAP's Bright Future Periodicity Schedule or the United States Preventive Services Task Force. This includes ACIP recommended vaccines. So that modifier can be used for any of those purposes to say, nope, no cost sharing. This belongs under the ACA provision and should not incur any cost sharing. This has helped in some instances, and in others it has not. So it's just something to keep in the back of your mind if you start to notice recommended services or ACIP vaccines are being put to the family. Modifier 33 could help in that situation. The link on the bottom is the resource to really define and explain what Modifier 33 was intended for when it was first developed. Let's look at when not to report IA codes. This seems kind of silly to discuss, but it's important. We don't use vaccine administration codes when we're giving an immune globulin. You will report the immune globulin product, which is the 90281 through 90399, and you will use an administration code. It's just not a vaccine administration code. So for example, you give the Synagis, the RSV immune globulin. You will report the 90378, which is the product code, per 50 milligrams, and the administration code is reported with 96372. It is not reported with a vaccine administration code. So keep that in mind. Immune globulins do not fall under our vaccine administration codes, and that includes the RSV or Synagis. The PPD, that's reported with 86580. This is not a vaccine or toxoid, so you will not report administration with the IA codes. You will also not report the 96372. This code kind of strangely already includes the administration. So the 86580 does take into account the administration. So when you're placing the PPD, it's strictly the 86580 code. Okay, we're just going to talk for a few minutes here on Illinois Medicaid and the VFC program. So again, under Medicaid, the NCCI edits have now been implemented. They've been in place for a few years. You all should be very familiar with them. They are updated 4 times a year, so we want to keep track of that. In 2013, the edit did come out bundling all IA codes and all E&M services, including preventive medicine services. So without using modifier 25 on your E&M service when billing the immunization codes, one service was being denied. However, since Illinois Medicaid does not pay on IA codes, this was not really an issue for Medicaid here in this state. However, some, if not most now, of the private payers are following this. So again, if you are receiving any denials for immunization administration or the E&M services, and you do not have modifier 25 appended to the E&M, resubmit. Now, one question that comes through a lot is what happens with a well sick visit? You do a well sick, but the child is not sick enough to not receive vaccines. They can still get them that day. you must append modifier 25 to both the well or preventive and the sick E&M service. Both must have modifier 25 if you're going to also if you're also going to report the vaccine administration codes that day. Here in Illinois, they want the modifier SL. You will report the vaccine product code and use modifier SL, which tells them that is a state-supplied vaccine. This is, there's a little bit of an exception here with the OB/GYN for the HPV. So if you're an OB/GYN provider, a lot of you are not VFC, but they're still allowing the HPV to be given. So you'll need to check in on that for Illinois Medicaid if you're on OB/GYN, but not a vaccine for children provider. The last and probably one of the most cumbersome things I want to discuss is the National Drug Code. This has become a thorn in everybody's side recently. More and more payers are requiring it. If any of you are TRICARE providers, they require it and have a very convoluted system that we have experts working on, and even TRICARE doesn't quite understand it. So it's a little challenging. So my take-home note on that is be sure if you are a TRICARE provider that you make sure your vaccines are being reimbursed appropriately. And what I mean by that is if you are getting underpaid or overpaid. There have been several audits lately where they're taking money back from TRICARE providers because of overpayment, and that is strictly due to both the NDC and the qualifiers that you're billing with. So just pay extra close attention, and if you feel you pay $100 for a vaccine and TRICARE is giving you $400, that's an overpayment. You really need to follow up on that because they are coming after practices for that money back. So we just want you to be vigilant on that. So again, it's more and more payers are requiring it, Medicare, Medicaid, TRICARE, Champus, a lot of the governments, and we're finding a lot of private payers too are requiring it now. It's used for all drugs given and now includes vaccines. We don't ever believe the Medicare system was set up for vaccines to be included under NDC, but private payers are interpreting in that, and so is some of the government organizations like TRICARE. Really, the FDA was putting together a unique drug number under the NDC in order to be able to identify specifically what was given. Unfortunately, our CPT and HCPCS code could represent several different types of drugs or vaccines, but with the NDC, that specifically tells the payer what was given. Most are given in the 10-digit form from the FDA. However, the HIPAA standard does require 11 digits. I'm not going to go over this too much. This is just kind of for your information. So if you do find a product that is listed as a 10-digit, this kind of shows you how to convert it to an 11-digit. The other question you want to ask your payers is what happens when you get it in a box? Do they want the box NDC or do they want the vial or bottle NDC? And this varies amazingly enough. Again, TRICARE has some very interesting rules that we're still navigating, so just pay attention to that. Let's go through some vignettes real quick. A patient or parent is counseled by a physician or other qualified healthcare professional on a 2 single-component vaccine. The physician or other qualified healthcare professional gives the vaccine. Patient is under 18 years. We're going to report our 90460 times 2. 2 single-component vaccines. Both criteria are met for the 90460. Patient or parent, same vignette as number 1, but the nurse gives the vaccine this time. Same outcome. Just because the nurse gives it does not change the outcome as long as the physician or qualified professional counsels. Let's look at this patient. A single component vaccine. Patient is 19 years old. Again, we cannot use our 90460 because the patient is over 18 years. So we would use the 90471 for an injection or 73 for intranasal. So the patient or parent is counseled by a physician. on one multiple component vaccine. The physician gives the vaccine. Patient is 19 years old. Again, 90471 or 73 depending, because the patient is 19 years old. It doesn't matter about the multiple components. We don't care about that once the patient reaches over 18. So the patient or parent is not counseled on two multi-component vaccines. Both are injectables. The patient is 5 years old. Again, because we do not meet that one criteria for the counseling, it doesn't matter how old the patient is, we are at our 90471 and 90472. Again, even with the multi-components, we don't count them. We had two separate vaccines, so one each, 90471 and 90472. Next one, the patient or the parent are counseled by the nurse on two multiple component vaccines. Both are injectable. Patient is 5 years old. It's the same outcome. Unfortunately, the nurses do not qualify as other qualified healthcare professionals, so we do not have that counseling component in order to report the 6.0. So we are left with our 7.1, 7.2 codes. All right, the patient or the parent is counseled on two vaccines as part of a well-child check. Because the patient is sick, the physician has them return 2 weeks later for the shots. When they return, the patient only sees a nurse. So what codes are reported for the counseling? None. Unfortunately, we don't get credit for the counseling when they do not take place the same day as the administration. And then when the patient returns, it'll be our 90471 through 74, depending on what's given. Because the counseling took place on a separate day and if the nurse counsels that day, it will not matter. Unfortunately, that is the way the codes are written. A patient or parent is counseled on 3-component vaccine given the same day are 2 single components. So we have 1 3-component and 2 single component vaccines, so 3 total components. No counseling is documented. Patient is 12 years old. I'm sorry. The 3-component is counseled on. 2 single components are not counseled on. So we've got our 90460 with 1 unit, 90460 with 2 units. That's for the vaccine that was counseled on. And then our 90472 with 2 units because 2 vaccines that were injectable were not counseled on. Remember, we can't report the counseling codes if there's no counseling done on that particular vaccine, and we can't report our 7.1. So this is just for the Illinois Medicaid. Established patient presents for her 13-year-old adolescent check. She's never received her HPV. The physician counsels. What is reported? So we'll report our 99394 for our preventive services and the 90649 for the Gardasil. Same patient returns 6 weeks later for the second injection, sees a nurse only. Again, we can report our 211 minimal office visit with the 90649 for the HPV. All right, that concludes the presentation. These are some resources on the NDC codes, some information on Illinois Medicaid. We have AAP resources here. They are updated pretty frequently, so always check back. This may require a member login, however. And here is a site for payer resources on all the immunization vaccine pricing. So feel free to look around that page for any information you may be interested in. Questions? Sorry, that went long.
No worries. All right, so if you have any questions for the presenter, you can go ahead and type those in on the right side of your screen, and we'll definitely answer those in the order that they are asked. Sorry, I'm trying to expand the screen.
There.
Here we go. Okay. Oh yeah, sure.
Okay. So the first question is, so a registered nurse cannot use 90460 or 61, and that is correct. They cannot. They are not considered other qualified healthcare professional in the eyes of CPT. If you get something different in writing from a payer, that's fine. Again, it must be in writing, but the overall guidelines from CPT say no. A registered nurse is not considered an other qualified healthcare professional. This next question has to do with the Men-B vaccine. ACIP is kind of wishy-washy on its recommendations. Unfortunately, that's kind of a lot of recommendations lately. It says not for routine, but then says you should consider giving it to adolescents 16 to 18. I believe it is routinely recommended. That is something I'm going to take back to my immunization team and double check. I'm pretty sure it is a recommendation at that age. And you are correct. The recommendations, I just read them 2 days ago. You're correct. They are very wishy-washy is a great term. So we will get back to you on that for sure. I believe the slides are going to be sent out. Somebody asked a question about slides. I believe they're going to be sent out after the presentation. Can you bill 99384 with 90460 and get paid for both? The 99384 is our preventive service code for older kiddos. As long as, again, I don't know the age range on the 84, the patient has to be 18 years and younger to report the 90460. If that is the case, then yes, you can report both. I recommend modifier 25 on the 99384, and you should get paid for both. If you are not, you will not be paid. You may not get paid, but if you're not getting paid, please contact the Academy at the coding hotline. We'll send that email out as well and let us know what's happening with the payers. Let's see. We bill Medicaid for HPV with 90649 or 90651, and it's always denied asking for additional information and never paid. Can't get an answer as to why. That's interesting. I would suggest sending that to the Academy. The Academy's email is aapcodinghotline@aap.org. Again, we'll send this out with the slides, that email address. But let's talk about that offline. I think we definitely have to find out from Medicaid what's going on and see a copy of the denials. And hopefully we can help you out with that. The last question here is if MA is not certified, 99211 cannot be billed, correct? That's a good question. I don't know the answer to that. If an MA is, if they're working in a clinical staff capacity, it's possible. I don't know the answer to that. I think I would have to look at Illinois regulations in terms of reporting incident to services, because 99211 is an incident to service. But my initial thought was no, because I'm not sure they'd be considered clinical staff. But again, I have to look at what the MA scope of practice is here in Illinois and if they require certification. And if they do, my thought would be no, they can't report 99211. If they don't require a certification and only require to work underneath a physician or other qualified healthcare professional, then my answer would be yes. So I don't know that, but again, I will be in touch since I know who you are.
All right. Once again, we'd like to thank Mrs. Becky Dolan for coming in and presenting for us. And also would like to thank everyone for joining us on today's webinar. You'll receive an email with a link to the PowerPoint slides, recording of today's webinar, as well as a link to the survey to be completed. We all hope that you have a great afternoon.
Thank you all.